students, this is your Dr. Prats and welcome to my masterclass. Today is the last of the series under odontogenic cysts, and we'll be discussing mainly about the inflammatory cyst, that is the radicular cyst, and a few other cysts. Let's roll. If you're new to the channel, we follow a questioning format. We start by understanding what is the pathology, why do we need to know it, the three hows, that is how did it occur, how to diagnose and how to treat, followed by a brief summary and tips and tricks to answer MCQ. All of my lessons have a learning objective. So at the conclusion of this presentation, you will be able to describe etiopathogenesis clinical picture, radiographic features, histopathologic feature, differential diagnosis and treatment of radicular cyst. Role of aspiration in the diagnosis of radicular cyst, and also we'll be discussing very briefly about retention cyst. Radicular cyst, the name itself says that it is associated with the root and very particularly peri-apex of the tooth. Apex is the area here. This is the apex of the tooth. Peri-apex is around. Peri is around. So it is associated with the peri-apex of the tooth, and hence it is also called as periapical cyst. So that is what is the cyst, and why do we need to know it is because it is the most common cyst. More than 52.3% of all cysts are comprised of radicular cyst or residual cysts, which we will discuss today. So as you know, caries is one of the most common pathologies a dentist comes across. An untreated caries will reach the pulp and cause pulpitis, and if that is left untreated, then it reaches the apex of the tooth, and that's how it results in the formation of a periapical pathology. So the tooth can be infected either by bacteria, which is in case of caries, and the bacteria could also attack whenever there is a case of trauma. And that bacteria, when it reaches the pulp, there is initial inflammation followed by necrosis. And the toxins has to exit through the apex of the tooth. It cannot exit through the crown. It has to exit through the apex of the tooth. And that's when it results in periapical inflammation. Let's look at a video to understand it better. So you can see that here there is a description of trauma as well, and how the bacteria attacks to cause the inflammation. So once the toxins reach the apex of the tooth, it stimulates the cell rest of molasses. Cell rest of molasses are remnants of Hertwig's epithelial root sheath. If you want more details, please go back to the first lecture in the series of cysts. I will put up a link in the description box below, which will give you more detailed explanation. Now we will continue. So these cell rests proliferate to form a granuloma, which is nothing but a sphere of cells composed of a lot of blood vessels and fibroblast and inflammatory cells, which acts as the first line of defense basically against the toxins that are reaching the apex of the tooth. Eventually, the central cells stop receiving the nutrition, so there is a necrosis in the center and there is fluid accumulation, resulting in enlargement of the cyst. Again, more details in the first of this series. And this is an inflammatory cyst because It's the inflammation which is the root cause of this cyst. So clinically, like I said, it is usually associated with teeth which have caries or any sort of trauma, and more than 60% of all jaw cysts are radicular cysts or residual cysts. It is very slow growing and it is asymptomatic in most of the case, and it is identified only when the patient walks into your clinic or maybe over routine radiographs. Uh, and it usually affects the maxillary incisors. Any guess the reason? Because it is one of the most commonly affected tooth by trauma, maxillary incisors. So that could be one of the reasons of these teeth getting affected. And also caries is also seen in maxillary incisors. So that's the most commonly affected teeth in case of radicular cyst. So non-vital tooth is a sine qua non, meaning it is the most essential feature of radicular cyst. So here you correlate with the pathogenesis. For the radicular cyst to occur, the pulp must be dead and necrotic. So that basically makes it essential that the tooth has to be non-vital for you to see a radicular cyst. The cyst is usually small in size. It never grows so big that it results in expansion of the cortical plates or resorption of bone or displacement of adjacent teeth. None of the things which we discussed in our previous sessions when it comes to other cysts like dentigerous cyst and odontogenic keratocyst does not happen in case of radicular cyst. But in some cases, it can cause palatal expansion and can grow pretty big in size, as you can see here. Radiographically, it is a very well demarcated radiolucency, meaning there is a radiolucency and surrounding that is a radio opaque rim. So I have told you in my previous lectures as well, this basically indicates that the lesion is slow growing and the body has enough time to create a defense and deposit some amount of bone at the periphery to prevent further damage or to repair some of the damage, if I can say that. And the differential diagnosis, let's discuss it here. The radiographic differential diagnosis is quite tricky in case of radicular cyst because periapical abscess, periapical granuloma, and periapical cyst, all of them share the same radiographic picture. All of them are associated with the apex of the tooth. All of them are radiolucency with a sclerotic border, and although there is a size criteria that anything larger than 2 centimeter must be considered as a radicular cyst, it is not the case all the time. We have different cases and different sizes of pathology, whether it's a granuloma or an abscess, which are coming in. So we cannot really say that anything which is bigger than 2 centimeter is a cyst. So again, we have to rely upon the histopathology as a standard tool of diagnosis. So this is the radiograph of the maxilla where I showed a palatal expansion of the cyst. So radiograph also, you can see there is a huge radiolucency, but it is still surrounded by a radio opaque border. And mind you, radicular cyst is very slow growing and very chronic lesion, and it might take years together for the cyst to form. After the tooth is extracted, this is how the periapical cyst appears. So this is the tooth, this is the apex of the tooth, and you can see how the cyst is attached to the apex of the tooth. and even when you take a cross section of the same histopathologically, you will see it very, very well. And you can see that there are some structures within the cystic cavity, needle-like structures. We will see what they are in the coming slides. So histopathologically, the epithelial lining shows varied thickness and it is stratified squamous in type. And the connective tissue wall or the connective tissue capsule is composed of bundles of collagen fibers along with some fibroblasts, which are active, and small blood vessels. The epithelial lining shows very characteristic feature in case of radicular cyst. The proliferating epithelium into the connective tissue forms several rings and arcades by enclosing the connective tissue within, and this is very characteristic, and the thickness of the epithelium could vary from 1 to 50 cells in thickness. That's quite big compared to all other cells we have discussed till now. So here appreciate that the rete ridges are more or less arc shaped. That's very diagnostic of radicular cyst. So if you remember in the first slide when we were talking about the gross, I showed you an image of the cystic cavity filled with certain structures, and this is a close-up image of the same. So this is nothing but eosinophilic coagulum containing slit-like spaces, which is nothing but cholesterol actually, and they're called as cholesterol clefts. But when we do the histoprocessing to prepare the slide for viewing under microscopy, the cholesterol is lost, and hence it looks like spaces, needle-like structures or slit-like spaces, and they're called as cholesterol clefts. Another structure which is quite diagnostic are presence of Rushton bodies. Okay, so these are also eosinophilic and are described as ladies' hairpin shaped structures, and there could be some hyalinized areas as well present. So the treatment of radicular cyst is simple enucleation, and it is quite effective, and this is a lesion which does not recur, and there are not many complications which are associated with it. Residual cyst is a cyst which is associated with an area where the tooth has been already extracted. That is why it is called as residual, meaning left behind. So the tooth is extracted, but probably the cyst was left behind. That could be one of the reasons. And the second could be that the tooth was extracted for some pathology, but the dental lamina or the cell rests which are present at the apex of the tooth, or the periodontal ligament at the apex of the tooth, has undergone some kind of proliferation and has resulted in a cyst. So these are the two etiopathogenesis in case of residual cyst, and radiographically you can very well appreciate this radiolucency, which is surrounded by radio opaque border, and you can see that the tooth is missing in that area. So that's the radiographic picture, and the history will show, or the patient will tell, that the tooth was extracted some years ago or months ago or whatsoever. So the treatment includes complete enucleation of the cyst, and we're good to go. Do not get overwhelmed, but today I think it was quite simple and easy. It was not at all complicated. So let's just run through it very quickly. Let's see how the radicular cyst itself forms. So the cause could be either caries or trauma, stimulate cell rest of molasses, and they proliferate to form a granuloma. The central cells undergo necrosis, and that results in the formation of periapical cyst. Yeah, so that's the etiology. And clinically, it is associated with a non-vital tooth. It is very essential because the pulp has undergone necrosis, and that's how the toxins have reached the apex and caused the inflammation. and it is asymptomatic otherwise and doesn't usually cause any swelling or drastic bone resorption or any of those. And radiographically, it's a well rounded radiolucency surrounded by radio-opaque border, but very difficult to distinguish with the periapical granuloma or periapical abscess. So the gold standard is histopathology. Epithelial lining is very characteristic when it comes to histopathology, shows rings and arcading pattern, and it is about 1 to 50 cells in thickness, and it also shows some other structures like Rushton bodies and cholesterol clefts. The treatment is simple enucleation with extraction if required, or a root canal treatment followed by episectomy. So let's talk about the multiple choice question which could be asked. So the stem is that the patient walks into your clinic complaining of bad breath, and on radiographic examination you discover a periapical radiolucency in relation to a non-vital maxillary lateral incisor. Histopathology shows cholesterol clefts in the cystic wall and an arcading epithelium. Just now you have finished discussing the cyst, so you know that the answer for this is radicular cyst. But let's just discuss what are the features which favor in finalizing this option. So the patient has no clue that he has this lesion. He has come complaining of some other thing, but you might have taken a radiograph to check for pockets or something else, and then you see that there's a periapical radiolucency in relation to non-vital maxillary lateral incisor. You might have seen it even during clinical examination that either there is a cavity or a trauma in relation to lateral incisor. And after you take out the tooth and you see the histopathology, you see that there are cholesterol clefts in the cystic cavity, and the lining shows arcading epithelium. So that is very, very positive of a radicular cyst. But in case of OKC, it has a very typical lining of basal cells which are showing a picket fence or a tombstone appearance, with nuclei polarized away from the basement membrane, and the thickness of the nuclei is just 7 to 8 cells in thickness, whereas in radicular cyst it is 1 to 50 cells, and in dentigerous cyst it is just 2 to 3 layers of cuboidal cells, which resembles the dental follicle or the reduced enamel epithelium. And eruption cyst also shows similar histopathology as dentigerous cyst, and it is usually associated with teeth which is erupting. Here it is associated with an impacted tooth, and OKC could also be associated with an impacted tooth and is seen in the posterior mandible rather than anterior maxilla, and in none of these cases the tooth has to be non-vital. So when we're talking about a non-vital maxillary anterior tooth, when the word non-vital comes, you must think of radicular cyst. We've discussed the important developmental cysts and the inflammatory cyst, which we did today. So I have just put up this image. Always visual things are retained better. So remember this picture just to uh, understand the location of different cysts in one go. So odontogenic keratocyst is the ramus of the mandible, or you can say posterior mandible. Dentigerous cyst associated with the impacted tooth attached to the crown. Periapical cyst or radicular cyst at the apex of a tooth which is affected by caries. This is the residual cyst where the tooth has been pulled off but the cyst has been left behind. This is lateral periodontal cyst. This is eruption cyst. So these are the cysts we have discussed and for you to remember. These are my references. I hope you liked today's presentation, students. If you have any doubts, comment below and let me know if you like any other topics. And for more such MCQs which we discussed today, please go to my website and you will find plenty under each topic. And there are also MCQs for you to practice on your own. Thank you.